Hello everyone, my name is Chyta Gohil, studying in Pharmacology third year. The topic of discussion in the following video is about hydrochlorothiazide. It is one of the medium efficacy thiazide diuretic. The content in this video will include history, its discovery, introduction, class, category and source, brand name, its therapeutic uses, mechanism of action, pharmacokinetics, adverse effects, contraindications, special precautions, monitoring parameters, interactions, patient counseling, and quiz. Starting with the history, two companies named Merck and Sebastian discovered the medication which became commercially available in the year 1959. It is on WHO's list of essential medicines. Discovery: Dr. George D. Stevens discovered this drug. He joined Ciba Pharmaceutical as senior research chemist and discovered two diuretics, namely hydrochlorothiazide and cyclopenthiazide. Introduction: Diuretics. Diuretics are drugs that increases the elimination of water, sodium, bicarbonates by affecting anyhow its reabsorption. It helps in increasing the urine output and gives relief to associated problems like hypertension, edema, and etc. Hydrochlorothiazide is a thiazide diuretic, also known as water pill, that helps prevent your body from absorbing too much salt, which can cause fluid retention. Hydrochlorothiazide is abbreviated as HCTZ and mainly works on the early part of the distal convoluted tubule. Class and category: Hydrochlorothiazide mainly belongs to the class of medium efficacy diuretics, Na plus Cl minus support. It is a newer agent in this group and is more popular because of its more potency, and as a result it requires less dose in clinical practice. Its source: Hydrochlorothiazide is mainly synthesized either by the reaction of para-formaldehyde with 5-chloro-2,4-disulfamyl aniline in non-aqueous media, or either with the reaction of formaldehyde with 6-chloro-7-sulfamyl 2H124 benzothiazine 1,1 dioxide in aqueous alkaline solution. Brand names which are available in the market are like BPzide, Hydride, Xenia, Chloride, and Aquazide. The manufacturers of the following were Sun Pharmaceuticals, StadMed, and others. They are generally available in the form of capsule and tablet. So these are some pictures which are available of the tablets which are available in the market. Moving forward, its therapeutic uses. It has diuretic use to relieve the pulmonary edema due to CHF, pregnancy, and nephrotic syndrome. It is also used in essential hypertension. It is first choice of drug. Diabetes insipidus, hypercalciuria. With recurrent calcium stones in the kidney, thiazides acts by reducing the calcium excretion. We will see the mechanism in the forward in the slides which will be seeing in the mechanism of action. So mechanism of action, I'll be explaining the whole mechanism of action through this diagram. So the very important thing in this mechanism is this NaCl and Na plus and Cl minus symporter or co-transporter, we can say. This sodium and potassium ATPase channel, this calcium and sodium channel, and this calcium channel. So what happens is the thiazide diuretics mainly acts on the sodium and chloride co-transporter, okay, and thiazide acts on the luminal part of the DCT, that is distal convoluted tubule. DCT is impermeable to that is water, and absorbs only the solutes. One channel called sodium and chloride symporter is present, as I said before. In normal individuals, what happens is when the fluid is passing through this tubule, that is DCT, sodium and chlorine is being reabsorbed through this particular symporter. In normal cell, the potassium and sodium ATPase channel, which is this, is present, and in this 3 sodium moves out of the cell. This is a cell, our cell, and potassium, that is 2 potassium, moves inside the cell, as a result of which this cell becomes sodium deficit. And then cell will now receive sodium only from two sources, that is this sodium and calcium exchanger here, and another one is sodium and chlorine symporter. So the sodium which comes inside the cell moves outside through sodium and potassium ATPase channel. As mentioned before, that is 3 sodium moves out and 2 potassium moves inside. During this, the sodium and calcium exchange, the cell gets calcium from this calcium channels. Okay, so the calcium moves inside the cell from the glomerular filtrate. Okay, this sodium and calcium channel gets calcium from this. Okay, and the calcium which is reabsorbed in the cell is due to the effect of parathyroid hormone. Okay, so what happens when this is the normal physiology which occurs in the DCT? What happens when we give the thiazide diuretics? So when we give thiazide diuretics, this Na plus and Cl minus importer is actually blocked, as a result of which the sodium which comes inside the cell is also blocked, and now there is only now the and so the sodium reabsorption which was occurring in this level of DCT is totally blocked. The sodium which was reabsorbed in the normal physiology is about 5 to 8%. Okay, so now this sodium which is not reabsorbed at the level of DCT will directly move to the collecting tubule. Oops. Okay, so the sodium will move to the collecting duct. Okay, now this sodium will get exchanged with the potassium, but the problem is that only some amount of sodium will get reabsorbed, like only 2%, and the others will still remain the same. So the sodium will now move into the or excreted into the urine along with potassium. Okay, so uh, now when the sodium is moved out, that is excreted, along with it water is also lost, and hence the diuresis occurs in the whole physiology. Now when we give thiazide diuretics, the cell gets sodium only from sodium and calcium channel, and because of this more and more calcium is reabsorbed from here. Okay, this is the okay, the more and more calcium is reabsorbed. Okay, to compensate, as a result of which calcium is deposited in our body. Okay, and this is known as hypercalcemia. Now the Ca plus 2, that is calcium reabsorption through the Na plus and calcium, that is sodium calcium exchanger, is due to the effect of parathyroid hormone, as mentioned earlier. So this particular mechanism is used in idiopathic hypercalciuria, where the excess of calcium is excreted and more amount of calcium oxalate stones are formed in our kidney. At that time, we give thiazide diuretics for reabsorption of calcium from the sodium and calcium exchanger. So this thiazide diuretics increases the excretion of solutes, as a result of which the urine becomes really very concentrated, and hence decreases the positive free water clearance. So net result of giving the thiazide diuretics is more loss of sodium and water, and hence diuresis occurs, then hypokalemic metabolic alkalosis, and increased calcium reabsorption. This increased calcium reabsorption is helpful in osteoporotic patients because there is calcium loss from our body. So this was the whole and soul mechanism of thiazide diuretics, that is hydrochlorothiazide. I hope you guys understood this one. Moving forward, we will go to the pharmacokinetics of the drug, the absorption. Now, absorption of this thiazide starts its action within 1 hour, but that can take about 6 to 48 hours. The bioavailability is about 65 to 75%. Peak plasma time is 1 to 2.5 hours, and peak effect of diuresis is 4 to 6 hours. Moving to distribution, The protein bound is about 40 to 68%. Metabolism is minimally metabolized, and elimination is about half-life is about 5.6 to 14.8 hours. Now the adverse effects, the electrolyte imbalance like hyponatremia, that is hyponatremia, that is a decrease in the serum sodium, this occurs because the hydrochlorothiazide prevents the DCT from releasing sodium. Now hypokalemia, that is decrease in the serum potassium. This is because the sodium and potassium exchanger exchanges sodium for potassium back into the urine. Now hyperuricemia, because they block actively the transport of uric acid from blood to urine, and therefore it is used very precautiously in the patients which are having gout, because in them the uric acid level is already very high. Now moving forward, hyperglycemia is also occurred. Now this occurs because hydrochlorothiazide stimulates glycogenolysis and also inhibit the insulin secretion from the pancreas. This may exacerbate the diabetes mellitus. Photosensitivity. Other adverse effects are photosensitivity, SLE, that is systemic lupus erythematosus, hypersensitivity reactions. So hypersensitivity reactions are mainly occurring in sulfonamide having groups. And as we saw in the synthesis, the synthesis of this drug includes the sulfa group. So the hypersensitivity reaction is obvious. Then orthostatic hypotension, diarrhea, vomiting, nausea, anorexia or others. Hyperglycemia, as I said, hyperlipidemia also. Then Gitelman syndrome. Now this Gitelman syndrome is when the mutation in the sodium and chlorine import occurs, which then causes inherited hypokalemic alkalosis, and hence Gitelman syndrome occurs. Other is hyperuricemia. Moving forward to the contraindication. It is obvious that we cannot give this in pregnancy because it can cause volume depletion as the effect of diuretics and can harm the fetus and also can cause the death of the fetus. Breastfeeding, anuria, lupus, and hypersensitive patients. Now, special precautions. Special precautions are to be taken in patients which have electrolyte imbalance. They should tell the patient should inform the doctor about his condition of electrolyte imbalance, or the doctor should ask himself uh, before prescribing this drug. In gout also, as I said before, hyperuricemia occurs. Then history or high risk of skin cancer, SLE, diabetes, and hepatic impairment. Now, monitoring parameters. As we have seen in the adverse effect, this drug causes serum electrolyte imbalance. So, we have to monitor serum electrolytes like sodium, potassium, and etc. Then, blood pressure is also to be monitored. Blood urea nitrogen, renal function test, fluid status, creatinine clearance, and assess skin for photosensitivity and skin cancer. Interactions. So when amphotericin B along with and corticosteroids, when given with this drug, that is hydrochlorothiazide, it can cause potential hypokalemia. Then when anti-diabetic drug is given along with hydrochlorothiazide, the dose adjustment should be done for the anti-diabetic drug as it causes hyperglycemia. The hydrochlorothiazide decreases the release of insulin and hence can cause hyperglycemia. Additive effect is seen when hydrochlorothiazide is used with the antihypertensive. Also, when opioids and barbiturates are used, it can cause orthostatic hypotension. Severe dehydration and electrolyte imbalance may be induced when using thiazide with other diuretics. But hydrochlorothiazide is given with loop diuretics. This is because it can increase the diuresis. Also, a hydrochlorothiazide is given with potassium sparing diuretic to boost the serum potassium. Cholestyramine decreases the absorption of hydrochlorothiazide. Therefore, when both of these drugs are given, it should be taken 2 hours apart. Also, NSAIDs, NSAIDs, where it in hydro NSAIDs increases the risk of renal failure. When hydrochlorothiazide is given along with lithium, it it interrupts the excretion of lithium, increasing the risk of lithium toxicity. Hydrochlorothiazide, when the patient is taking a hydrochlorothiazide, he shouldn't be taking the alcohol because increasing the risk of orthostatic hypotension. Patient counseling, it should be given or it should be taken with food. Because it can cause GI disturbance, as we have seen in the adverse effects. This medicine may cause dizziness. If affected due to this, then the patient should be advised to not drive or operate any machineries right after taking the medicine. This drug can also cause photosensitivity, so the patient should be advised to avoid the direct exposure to the UV light or sun, and is advised to wear sunblock or sunscreen. Now, quiz. So first question is that mechanism of action of hydrochlorothiazide includes release of the NO, inhibition of reabsorption of sodium and chloride, active synthesis of cGMP, or none of the above. So the answer is inhibition of reabsorption of sodium and chloride. As we have seen in the mechanism, it acts by inhibiting the sodium and chloride symport. So yes, the answer for this question is inhibition of reabsorption of sodium and chloride. Moving to the second question. Adverse effects of hydrochlorothiazide are hypersensitivity, hyperkalemia, hypoglycemia, or hyponatremia. So the answer is hypersensitivity. I also give the reason behind this, as it includes the sulfur group in the structure or in the synthesis. Third question. Thiazide acts from which side of the tubule? So distal, luminal, both or none. As mentioned before, it acts on the luminal part of the DCT and that too early part of the DCT. Okay. Fourth question. So the amount of sodium reabsorbed at the level of DCT is 15 to 20%, 10 to 15%, 5 to 8%, or 2 to 5%. It is 5 to 8%. 5 to 8% of the sodium is reabsorbed at the level of DCT. Last question. Long-term thiazide therapy can cause hyperglycemia by reducing insulin release, interfering with glucose utilization in tissues, increasing sympathetic activity, or increasing the corticosteroid secretion. The answer for this is reducing the insulin release. So, summing it up, I hope you guys understood what I wanted to explain you guys, and thank you for watching this video.